I will hand over formally, as it were, to Morag Harty. Morag, if you wouldn't mind introducing yourself, and you can carry on.
Good afternoon, everyone. My name is Morag Harty, and I'm the Tech Programme Strategic Lead for Scotland. Been in this post now for actually over a year. I came in for a few weeks, and as most things happen, it sort of went on from there for some reason. So I'm very delighted to speak to you about the remote monitoring, home health monitoring, as was the Tech Programme, very much a large part of that. So some of you will know all of this, and probably some of it will not be very new to you to start with. However, we did put in a little bit just to make sure everyone was in the same wavelength over this. So some of this will be new to people who haven't heard of scale up blood pressure and Florence and so on. So apologies to those who have already seen some of this, but just to put a bit of background into this to go forward. My colleague Scott Henderson's on the call as well, and we'll be telling you what the work we've been doing, particularly in the last 2 or 3 months. So just a bit of background there, those of you will know this, we had the Tech Programme, the scaling up towards home and mobile health monitoring, and that was way back. It was actually 2015 to 2018, which was the original Home and Mobile Health Tech Programme. And those economic and the summary reports are there on the webpage if anyone wants to have a look at those. And they set the background and the sort of foundations for us moving forward into the Scale Up Blood Pressure Programme as a whole. National Scale Up Blood Pressure Programme was launched just over 2 years ago, over a year ago rather, a year past in November, started just about a year ago. It's a collaboration between primary care. We had applications in from a number of partnerships, IGIBs and health boards, and 8 of those were successful, plus another 3 tests of change, and there was a total of £1.2 million, which was capped. We also said we would develop a Dortmund solution. So one of the key issues that had come up for all of our home monitoring was actually working out how we can get the results of home monitoring directly into particularly GP notes, because that was always a bit of a barrier, and people found that was a deal breaker, particularly in GPs. They wanted those results just coming straight in. And we put together a guidance pack, which I have to say is now pretty out of date. It was a lot of work in the process, and we will be redoing this. We will be redeveloping it and bringing it up to date, adding in some additional pieces of work to it, but streamlining it a little bit and making it a much more web-friendly guidance pack that will then go on to the new Tech Web page and be there for people to be able to get a lot easier than the original version of it, which was a lot of work and well done, and thanks to all of the partners who helped us with that. So it's not saying that's not there, but certainly try and slim it down a little bit and make it more fit for purpose going forward in this new world that we're finding ourselves in. So the objectives were very straightforward. We wanted to support our large scale up. We wanted to hit at least 50% of our primary care general practices and really get that moving on blood pressure. A lot of evidence, and there was a blood pressure task force set up. There was a monitoring a blood pressure report that came out showing us some really quite startling figures around the 1.2 million appointments across primary care every year in Scotland for blood pressure monitoring alone. And if we could actually manage to control blood pressure, have it properly managed, and give people the ability to do that, then we could actually show a reduction in the impact of long-term conditions like stroke and heart failure, life-threatening conditions. So lots of work went on there, lots of clinical input to it, and we managed to produce protocols on the Florence text messaging system, which were the national protocols that could be adopted and adapted for any of the board areas that wish to do so. And that went from the supporting diagnosis to medication management, and then the long-term monitoring. So aiming there at actually reducing the number of face-to-face appointments. Well before COVID hit us, we were looking at saving travel, saving time, saving effort, and at the same time improving the clinical outcomes for people. So just to go back a little bit, over the last few years, we've had partners from right across north to south of Scotland. The ones in green are the ones who actually ended up in the Scale Up Blood Pressure programme, but notwithstanding, we had some very important partners in the Western Islands and Argyll and Bute, Inverclyde and NHS Fife in particular, who have been involved in other tech programmes, other health monitoring programmes, and have been using this for quite a number of areas. Dumfries and Galloway and the Borders, both were tests of change, along with the East Renfrewshire. And as I say, the others had substantial funding. Have to say, I haven't put figures up there because we did get off to a fairly slow start in some areas, and some areas haven't quite managed to get off the ground yet. Lots of that was around the usual suspects of finding recruitment of staff, getting the Florence licence wasn't helped by that provider changing their ownership and some IG issues that arose from that, and these are still being worked through, so I'm not going to dwell on that. However, there are very good reasons in some areas where that didn't quite take off the same way. The integrated solution required help from NSS. They did a fantastic job, and all credit to them, but we also had to link in with our local e-health colleagues. And that again, they had to build these sort of parts into their work plan, which wasn't always easy in every area. However, when it works wonderfully well, and it's been a real boon to the GPs and their practice staff. We always knew we would probably think about something other than just general practice, so we already had partners when they put their funding bids in that they would look at all sorts of other areas where blood pressure monitoring in particular could be key, so pre-assessment for surgery, stroke services, leisure and culture, where they were doing something around weight management. So lots of other areas, both in acute and secondary and primary care, where they felt that blood pressure monitoring could be extended, and there was certainly moves towards that quite significantly. We were starting to see things happening, absolutely, but we also were looking at beyond blood pressure. So over the last few years, this is only a very small activity that we've been doing for home monitoring. Everything from the places that you might expect, things like COPD and asthma, smoking cessation, but some areas that you might not think of, like sexual health and continence and pain management. Speech and language have used it, musculoskeletal services, so many more right across Scotland. Board areas had used a very simple monitoring system to actually support their staff to provide the care to their patients in a different way, seeing the benefits of getting key information through, which made it an informed consult when they did have a face-to-face consultation, and actually helping patients, more importantly, to manage their own conditions, letting them see how they could actually see when things were going wrong, a trend that was happening, asking them to get help when they had, or simply encouraging them to take healthy lifestyle advice and coming to the conclusion that, yeah, actually I do have diabetes, I do need to be increasing my activity, because if I don't, then I'm going to store up some trouble for myself. Beginning to know when to take their asthma inhalers, knowing when COPD, they came downstairs in the morning and their coughing was a bit worse and had a bit of a spit. Oh, I do something now about it. So lots of good outcomes there demonstrated across Scotland, and all credit to the teams that supported those clinicians carrying those ones out. However, I'm going to pass across to Scott now. I'll stop. I stop sharing now, I think.
That's fine.
You take over.
Okay, thank you. Hello everyone, I'm Scott Henderson. I'm a Scottish Government advisor attached to the TECH programme, and I've been in and around remote health monitoring for a number of years now. Morag was just telling us there about all the work that we had planned when it came to all the beyond scale up BP, and of course along comes coronavirus, and of course everything changed. And like everybody else in health and care, we've had to reassess and to reevaluate and to reprioritize our work. The tech program director, Margaret Wariski, was asked to establish and coordinate the national response for remote monitoring and self-management. And within the program, we've had to identify which other tech work would be paused to allow us to reprioritize our COVID response. And I'm sure that many of you who are on today will have had very similar experiences. So our initial assessment for that COVID response looked something like this slide. We were very aware that there was a growing need for self-care at home. The nature of COVID-19 disease means that people can appear to be reasonably well, although symptomatic, and to be quite stable, and then to have a very sudden deterioration in condition, which can see them landing in hospital really quickly. So we identified that there was definitely a need for monitoring of patients, perhaps discharged from assessment centres straight to home because they weren't unwell enough to be a hospital admission, but still needing to have some sort of supervision there. Certainly early discharge from hospital, and there's quite a lot of talk about step-down beds and how do we support those hospital-at-home models and support in care homes. And on the step-down beds and some boards, there has been some local procurement of biometric continuous monitoring solutions to help with that. I think in all cases they have not been required as yet, and hopefully they won't be, but remain part of a resilient response. We also identified that although all the focus at that time was very much COVID-19 patients and about the surge in demand, we were also very conscious of the fact that we've got cohorts of non-COVID patients who are also in need of continuing support through our services. So those were particularly the high and medium risk shielded groups. Recognition that with the suspension of routine services, that there are, across many specialities, there are cohorts of patients who will gradually, and some less gradually, will deteriorate over time. So the longer you have this lockdown and suspension of services, then the worsening that their condition will become. And again, from a non-COVID perspective, care home residents were on our radar because very much their normal primary care services have changed beyond all recognition. As we move into recovery planning, the scope of our response is very, very likely to change. We're now focusing in on supporting local boards in their recovery plans, particularly around the triage of patients into these gradually resuming out of patient services. And there's a need for support for returning and the gradual return of some primary care services as well. And we're now getting a much clearer picture of the digital supports that are needed for care home residents. So what has actually been done over the past number of weeks? Well, in terms of COVID-19 and monitoring services, a Florence pathway has been developed for COVID-19 patients to support that monitoring that I mentioned just a moment ago. This has been developed in the Florence platform because that's what we had in front of us, and it was the quickest way to be able to get something up and running really quickly. It's been a fantastic collaboration to be able to put that pathway together, and today it is actually live in NHS Highland and being tested with its first live patients. Another example of the work that's been going on is the perinatal pathway, and Maura will tell you a bit more about that in a few moments. There has been a great deal of really good work being carried out around remote monitoring and what is becoming known as asynchronous appointments. And we've been very conscious that we need to be looking at that work and reviewing these current innovations to see what is it that we can scale up because it's working well, What are the things that maybe we need to pause because we're not so certain about them? So that work is still in hand, but a couple of examples of projects just to try and bring that to life for you. We've got a very innovative COPD project running in NHS Greater Glasgow and Clyde, whereby they've been able to show for those kind of brittle COPD patients, they've been able to show a significant reduction in hospital admissions. There's some very interesting work around machine learning embedded in that project. So we're currently reviewing how we might be able to support the continuance of that and some local scaling around that. Another example would be digital dermatology services, where patients are able to send in photographs to specialists so that they can be triaged into the appropriate care. Again, this is a project that's been started through SBRI funding in Forth Valley with partnerships with Greater Glasgow and Clyde and Grampian. So those are just a couple of examples of the many projects that are extant at the moment and are kind of under review as to what we can do as part of a national response. The third item there is the digital remote health monitoring platform. So we identified pretty early on that although Florence has been a great friend and ally to us in terms of being able to develop services and to be able to grow and expand, the range of potential demand, the variance in the types of service that we need to be able to provide, the multi-channel demands from our patient cohorts meant that we probably need a different solution. And I guess we'd recognized that before COVID, and that's why we were carrying out our strategic national procurement. That strategic procurement is still ongoing, and we've reached the point where we've closed it to applications. We're going through the initial, what's called an ESPD stage. We had 21 applications, so we're having to sort through those to create a short list to see who we're inviting to next stage. But in the interim period, with the help of DHI and the team there, who have been very supportive, we were able to do a market survey against a very high-level list of requirements, and we were able to identify a single supplier that could help us in the short term while that strategic procurement is being carried out. And that organisation is called In Healthcare. I'll tell you a bit more about that in a few minutes. So what I'm going to do now is I'm going to hand you back to Morag, because she's going to be able to take you through the perinatal pathway, because I think it's important that we share that work. It's just been created in the past few weeks. It's been a fantastic piece of work, and Morag, I'm just going to hand back to you.
Okay, thanks. So, can you still see that all right? That's sharing okay?
Yes.
Yep, okay. So technology supporting maternity care is a programme that's being worked through by the Perinatal Network in Scotland. So from a very high level, from the Chief Nursing Office and the Chief Midwife down to local board areas. And they have actually mandated the use of Near Me and a pathway for mothers or mothers-to-be in their pregnancy journey. They recognise right from the very start there that the COVID situation was telling pregnant women to be locking down for up to 12 weeks at least, and throughout their pregnancy, and to avoid unnecessary face-to-face contact. And as many of you will know, that usually can result in actually quite frequent clinic appointments. So how could they actually make this easier but keep it clinically safe, because at the end of the day you've got a mother and one or more unborn babies to look after. So how could they do that safely? So there's a huge amount of effort put in from clinicians, senior obstetricians, midwives, and as I say, the whole backing of the Scottish Government Chief Nursing Office. They started off by looking at Near Me, which was absolutely right. We'll have the virtual appointments. However, quite quickly they said, well, we also need to be doing some actual monitoring of situations. So blood pressure and urinalysis is the two key areas that they need to keep an eye on consistently, and also know when things are going wrong. The BadgerNet system that they use in most of the ward areas isn't really set up at the moment to allow the mother to put in readings. We knew from our experience, we brought Professor Brian McKinstry and myself became part of the steering group for this, because we were able to bring the experience from our Scale Up blood pressure work and the research behind that to bear and support this new programme for pregnant mums. What we were able to sort of try and recognise was that just the same as the blood pressure being taken at home for routine hypertension management, we know that it's far better to be taking it in a relaxed environment. It's much more likely to be accurate, and that it's far better getting a series of readings than the one-off reading. And we did our best to support the clinical group, saying, you know, if we can do some remote monitoring, this might be actually better than simply trying to take a blood pressure and send it in by text message or email it in or tell the midwife over the phone, because that puts pressure on. And if we get a series of readings, that might actually be much more conducive to a relaxed mother, especially if she's got other children in the house and with COVID and everything else going on. I don't think it takes a brain surgeon to kind of understand that that's maybe a good way to do things. So there was a huge procurement exercise. The blood pressure monitors that we had have a framework for our routine hypertension, which are validated monitors, but they're not validated for pregnancy use. So they had to look again, they had to try and source them. And they have secured 5,000 monitors, which are being distributed to all board areas on a pro rata basis, depending on what their pregnancy rates are like. And we've put together a validated monitoring protocol, I say, with the clinical guidance from the Royal Society of Obstetricians and so on. And we have a blood pressure and urinalysis protocol built on Florence. I am very happy to support. Before I came on this call, I discovered that the very first mum has been recruited onto that programme today. It was slightly delayed because the blood pressure monitors didn't arrive out at the two board areas who had agreed to test this out, which were Lothian and Lanarkshire, as being two large areas, and also very comfortable with using Florence. So that's been put on there. It's a national protocol, and once we've just tested that out, that will be made available to any other board area who would want to use that one, and we'll share it with them. It fits with the guidance that the mother gets. It's not like any other remote monitoring. It is not a yes, take this, or no, you would receive care. Their normal care will continue if they can't use monitoring. It's up a clinical guidance, as always, a clinical decision from the midwife of what's suitable, either for the near-me appointments or for the remote monitoring. They are targeting the high-risk mothers with pre-existing hypertension, with cardiac conditions, people who have previously had preeclampsia in their pregnancies. Those will be the mums that will be targeted first for some remote monitoring. However, that is intended to go further than that. We are doing 2 tests of change, I say, in Lanarkshire and Lothian, and we were using that Florence SMS. It is simple, it is very straightforward. We're using it for that. It's not going to link into anything at the minute. The midwives will be doing the monitoring, and they appear to be quite happy to do that, and we'll support them, providing the training, just as we've done with everything else in the past. They're up for it. They can see the advantages of it, and it really was just getting messages that were quite straightforward for the mother and quite simple. However, making sure that those alerts could be responded to, and they do get a management plan home with them that gives them advice to look out for any symptoms. And like all of our home monitoring we've done for both COVID and COPD and everything else, if in doubt, you seek medical help. This is not 24-hour continual monitoring in any shape nor form. However, they are recognising this could be an advantage, and I'm hopeful that this will continue once the COVID danger has passed. This is all being supported by the NHS Near Me video consults. So like everything else, they're able to actually see their results have a suite of results that again kind of have those informed clinical decisions, and when they have their near me consult, they will still be attending the hospital where that's required. They will be advised to contact their midwife where that's required, and they will be brought in for further investigations should that be required as well. I've put the network down there. There is the perinatal network. It is coming under very much the Near Me, NHS Near Me blanket. However, we have got that remote monitoring aspect to it where that's possible. So let's hand you back to you, Scott, for InHealth. Is that okay?
Thank you. Just because I'm aware of time, Scott, while you come back on, I'll just mention we've had a couple of questions and you may have actually covered most of this, but I've also shared the link for the perinatal network Near Me information in the chat. So does the maternal pathway offer funding for boards for texts using Florence? That was one question. I'm not sure if you've fully answered that.
We will discuss that with any board area that's wanting to use that. We would be able to, we are badging it under the Scale Up Blood Pressure. So if there was additional funding required for text, but since quite a number of board areas haven't actually started their blood pressure scale up in the GPs, then we would look at that, but we'll look at it sympathetically because we did make that point. So it would be a discussion to have, and certainly it's not a definite no, let's put it that way.
Okay, thank you. Thank you, Erica. That was from Erica. And a question from Gomindu. How does the central station receive the remote monitoring values? I think you've actually partially answered this one. For example, blood pressure. Is it by email, by text?
The Florence system is a text messaging system to the patient texts in the blood pressure, their urinalysis results, and the clinician sees them on a web page. So they can then download them and drop them into notes if they wish as well.
Thank you. And finally, does the procurement, I can't speak, does the procurement of the new remote health monitoring platform dictate all services move across to that? Or is there a case of if it's not broken, don't fix it, i.e. Flow remains a viable tool and a combination of tools, including Near Me, might be the most productive? That's from Alan. Alan, that is a long question.
Yeah, we if people are comfortable using one, we're not saying it's not. So boards have the license for Florence if they want to continue to use that. Certainly for maternity, that would be fine. Again, it's up for individual board areas to decide what's going to be the best fit for their services that they're requiring remote monitoring for. So
okay, thank you. And I'll go back to you, Scott, carry on.
Okay, thank you very much. So we carried out over a number of weeks, about 3 weeks. I don't think I've ever been involved in a procurement that's taken quite so little time. That's both inside and outside of public sector. Again, it was very much the great support that we had from DHI allowed us to be able to identify in healthcare as the solution that was of most use to us in the short term, particularly around COVID response. So this has been an emergency procurement. What that means is that this is a platform that we have access to for the next 12 to 18 months, but probably no longer than that because it's a COVID response, it's emergency response. And we didn't have to go through all the hoops that you would normally go through for a procurement. So what can I tell you about this platform? We essentially went out and asked for all the stuff that we put into our strategic procurement, or all the most important things around the flexibility, about the multi-channel approach. So yes, you can continue to use SMS, but there are other options. So there's app or web channels which don't have the additional costs of text messaging. There's automated call, which does have a cost to it. There's a specialist app that can be used in care homes so that you've got multi-user, that sort of thing. So immediately it gives us a lot more scope in terms of who we're reaching and how we're reaching them, and the types of conversation that you can promote using this type of technology. It is device agnostic, so you can use pretty much any device that you want. And when it comes to sensors, again, it's not particularly tied into any particular brand or any associated products. The platform itself features what's called the Pathway Engine. Those who have used Florence will be familiar with this ability to be able to create your own protocols. This is the way that it's done in the InHealthcare platform. I've been told that it's more user-friendly in that you can see what you're doing as you're creating these questionnaires and processes. You can see visually what's going on, but you do need to learn a little bit about XML as a programming language. But there's a library of terms that you can pick up pretty quickly and use to construct your local pathways. The platform itself offers quite a lot of scope in terms of integration with other systems, other NHS systems, which is, I think, going to be quite important. It's not our first port of call on this, but I think that it will be very important in the coming weeks and months. And there's very nice analytics and reporting features in the background, and it can, again, through integration, be able to look up demographics so that for purposes of onboarding patients, then with the appropriate integrations, we can look patients up and just add them in rather than having to type everything in to onboard somebody. Some screenshots here of what it looks like. The big red bar, it looks a bit ugly, but that's to tell us that it's in the sandpit mode, so you can design all to your heart's content in the sandpit mode. You can see it's pretty clean, pretty straightforward. The question set that you see on the right hand side there is just an example, but you can construct things so that you can have hidden questions or questions that only appear if a certain answer is given earlier in the flow, which I think is really interesting. There's lots of nice features to it, but I think one of the big attractions is that it is also quite simple, and I think that we can be able to deploy quite a range of things in fairly short time. I mean, it's not a panacea, and it's not something that's going to be available tomorrow to everybody, but we are going to be able to significantly enhance the services that we've been providing to date using a platform like this. So I guess in summary, the emergence of COVID-19 has highlighted the need for remote monitoring for services in health and care to such an extent that we've had to accelerate a lot of our plans for the delivery of services in this area. As we move from response to recovery, there is great demand for service redesign, and we will continue to support that both with emergency and strategic procurement and with service development support. We really do have an opportunity now, I guess, just with the circumstances that we find ourselves in, with the tools that we now have and the skills that we possess, to be able to create whatever the new normal is, and to be able to share that and embed it for the benefit of all the populations that we serve. So Morag and I would be delighted for you to come and join us in that. And I'll now open up to questions.
Thanks, Scott. I'm just checking the chat. I don't see any new questions. So if anybody has a quick question they want to add, you can either unmute yourself or you can type it into the chat function. I'll ask a question that I've asked a couple of times this week on other webinars. And that was really about staff receptiveness. I mean, you've mentioned several times, both of you have mentioned the speed at which you've been working, and obviously it's not just yourselves, there's whole groups of people involved in this. But in general, have you found staff receptive to the idea of expanding the use of technology, or some staff it might be a new use of technology, or have you found staff generally saying, no, we've got enough on our plate right now? So in other words, are people taking the opportunity?
Okay, so interestingly, if I go back to the scale up blood pressure, we expected really to be down at zero recruitment when COVID started, because we thought, oh, that would be that gone. And what we're now beginning to see as the primary care are looking like secondary care, standing up their services again and resuming, once they get over the initial shock of COVID and the impact and so on, they suddenly started to think, wait a minute, how are we going to manage all these long-term conditions that we've actually pretty much parked for 8 weeks or so? And we're beginning to see practices now coming back and asking to increase, and that's been replicated in a few of the board areas that the project team have been speaking to, where they've had a renewed interest, and indeed starting to see other services who previously poo-pooed it, didn't really sort of see the value of it, are coming back, particularly for the remote monitoring. Clearly, near me is the big one on the block. However, people are realising that that alone is not always enough, and we can be doing something else as well. So I think the you know, if there's any advantages to be had here, this is about making everyone aware of different ways of working. And as Scott says, the new businesses of usual, and I think there's a real appetite from boards who are having to put in their mobilisation plans. Their recovery plans had to go in yesterday, thinking, how else can we do something, whether that's through their modern outpatients programme, their recovery programmes in primary care and secondary care. So I'm cautiously optimistic that we'll see a real change, and a change from the public as well, which is absolutely more important, if anything, in that they're seeing, I don't always have to actually see someone face to face, because they're getting used to this idea of not having to go to a clinic. So yeah.
Thanks, Morag. And I think we've long said that putting the technology in a service improvement kind of mindset is just as useful, rather than trying to see it as something just temporary or short-term or project-led. A couple of good questions here from Eric. I think both are not both, Erica, both are about in healthcare. So Scott, I'll put these to you. You've indicated the in healthcare wouldn't immediately be available to everybody. So if people are interested, how do they get access? So first.
So that's the first question. I think that probably the best thing to do is see if you can get along to our campfire session, which we're holding tomorrow afternoon, and there's one the following afternoon as well, where we're starting to open up the discussion exactly about that sort of thing. Past experience has told us that you don't just say we've got a great idea and then just roll it out and hope that it's going to work. We're going to be a bit more measured about it than that. We also are kind of very aware that there's quite a range of demands, and that there's going to be a need for some sort of prioritization around service development here, because we will likely have some restrictions around our capacity to be able to serve everything all at once. We're treating this mostly as a recovery phase initiative, and with that we're looking to be able to support as much as we can over the coming weeks, but more importantly over the coming months. So it's about getting the right care to the right people at the right time, and working out how we can support that in the most efficient and effective way. I'm sorry that's not a black and white answer, but it's the best I can do for now, and I think that we have to have the conversation about how people want to engage. And like I say, that to join that conversation, there are 2 sessions, one tomorrow and one the following day, where there'll be an opportunity to participate.
Scott, well, Erica has registered for the campfire. I don't know if it's possible for you to add a link for that to the chat in case anybody who would like to join doesn't know about it, or we can circulate it by email. The other question around in healthcare was, will the in healthcare system have a similar function of reporting tool that will send a report to DocMan for GP practices? I hope I've read that properly.
Yes. So short answer is out of the box, no. Because that needs to be designed, but as a system that's pretty flexible around these things, then yes, I would expect that to be part of it. what we have to do is make sure that we're designing services correctly from the outset. So that's why one of the, another reason why we can't have everybody provided with everything tomorrow, but it may take a little bit of time to get everything up and running. I don't know what the appetite will be for people to run with services and then add in integrations afterwards. It's all part of the conversation that we need to start and conclude pretty quickly over the next couple of weeks.
Just to remind people, there was a letter and an attachment went out to all chief officers asking them for a clinical lead-in project and some expressions of interest around this COVID monitoring. And as I say, this has been set up for COVID monitoring rather than initially, okay, rather than for other services. However, we kept it deliberately wide so that we could include other services as part of the COVID recovery part to things, but it was set up originally as a symptom monitoring tool, or that was where we set our stall at the very start. But as I say, as most people will understand, this has moved on a literally daily, not at times hourly basis. So we have to sort of really say, all right, we'll move with this. We're not just saying it won't happen, but yeah, there's that capability there, which is the most important part to it.
Okay, thank you. That's a really good point. I think we will stop there. We're just slightly over our time. We said we would try and keep it short. And really, really thank you to the speakers for taking the time out to join us, to Scott and to Morag, and also especially to the people who've taken time from their diaries to join and ask questions and engage. So really appreciate that. And thank you very much. I will stop the recording. And final reminder, the webinar will be available on the TEC website. Hopefully before the end of the week, possibly tomorrow, but let's hope so, because we've got multiple webinars to upload. So thanks very much to everybody, and cheerio.